the A1C reduction is more of the change of the other anti-diabetic molecule, not of the saraglitazar alone?
Well, it could be more than anything else the insulin sensitization. How much of insulin resistance has been overcome, you can't quantify, because we haven't done HOMA beta or HOMA IR. If we did HOMA beta and HOMA IR, then we would know how much insulin. I think it's a function of insulin resistance. It's like a cricketer who is very good at the nets and makes all the runs on the Sunday matches, but you put him into Adelaide and he flops all over. So it's difficult to say.
The drug is still not approved for type 2 diabetes treatment.
It is not.
It is yet not approved.
It is not primary.
Yes.
Yes.
So we should be happy if it is approved in this segment as well.
Well, I'm quite sure this would be the next thing. But the reason why it would not be approved in the ADA or EASD guideline is because it has such a pronounced alpha action that everywhere, if it is approved, it would have an addendum to be used with patients with hypertriglyceridemia. So it is for that fraction of the population.
Thank you.
Where I would like it to be used more is in the cardiovascular patients, especially all patients who are diabetics with cardiovascular issues in our country could benefit by using this drug, especially if their triglycerides, which usually are high. We know the diabetics have a high flotation of triglycerides.
Can we use it in hypertriglyceridemia without diabetes?
Yes, you can, because it only causes insulin sensitization. It won't cause hypoglycemia. So you can use it.
Sir, due to saraglitazar patient diabetes taking insulin.
Of course, because I have, as a diabetic specialist, have been called to see a post-operative bypass patient who was on 80 units of Lantus and 30 units of Novorapid, not responding. He had had a bypass. All I did was add 7.5 of bioglutasol, knowing full well that there is a central line to monitor fluids and other things. But it was more important for me to control his sugar than worry about weight gain at that time, and it brought everything down. So with insulin, of course you can use it. Should we say last question, because the others are...
So actually I want to ask a question from a practical point of view. I know practice in the rural belts, physician. So you suggest the starting of the drug, so the patient comes. First line of drug with metformin, or you want to wait for 3-drug combination and start it. Patient having diabetes and dyslipidemia.
If you have diabetes and dyslipidemia, and if you haven't yet started metformin, you are wrong.
Yeah.
Metformin
We'll start metformin.
is the soda of the diabetes.
We'll start metformin, sir.
You can't have a bar without soda.
Start
so
metformin.
you have to have metformin.
That's right.
Then if he has very high triglycerides,
That's right, sir.
then you would like to add this drug and watch his sugar simultaneously.
And then
not he needs something else. He might, being a weak anti-diabetic,
Then we
he
can-
would need a third line of treatment. But if he doesn't, it's very good.
And we can-
And this is not as expensive as the molecules to follow.
That's important. And then we can also add on to 3-drug combination and
Of
then
course.
see the watch the decrease the
Of
dose.
course, you can give it with sulfonamide,
Yeah.
you can give it with biguanides, you can give it with with the SGLT2s, you can give it with the gliptins. You cannot give it with the glitazoles.
Thank you very much. Thank you for your questions, and thank you, Dr. Thakkar, for his lucid presentation. Now the time of felicitation. Now the time of felicitation. May I ask Dr. Patni to come over and hand over the small memento to Dr. Thakkar.
I must say, one of the most enlightened interactions. Your questions were focused and very practical. Thank you.
Thank you very much. Thank you.
Good morning, ladies and gentlemen. It's a matter of great pleasure to be with you this morning. And first and foremost, I would like to thank Dr. Vijay Patni and his colleagues for inviting me and giving this opportunity to speak today. And the topic of my presentation is SGLT2 inhibitor, a new paradigm in the management of diabetes. It's a recently introduced molecule in our country, as you all know. I'm going to speak about the brief concept of the SGLT2 inhibitor. Few studies which show its efficacy not only in the term of the hyperglycemia, but extra hyperglycemic effect also. And related to the side effects, its adverse events. So as you know, the diabetes is a global problem. It's a bigger local problem, I would say. If you see the data of 2004, all over the world there were 171 million patients in 2000. And it was predicted that by 2030 there will be 366 million patients. But if you see the IDF Atlas of 2013, the data has entirely changed. In Indian figure, in 2000 there were 32 million patients, and it was predicted that by 2030 there will be 79 million patients. And what happens now that in 2013 at least, in all over the world there are 382 million patients. In 2013, by 2035 there will be 592 million patients. Means the figure has drastically changed, and this is the global burden of the diabetes. And not globally, but in our country the situation is much serious. So this was the epidemiology. If you come to the diabetes management, there are certain barriers for the effective treatment. The most important thing which we know is the natural history of diabetes, that with the passage of time the diabetes progressively deteriorates. The beta cell function deteriorates and its control deteriorates. And there is another barrier which is very important, that is the fear of hypoglycemia. And third is the weight gain, which is either because of poor lifestyle or it may be related with the use of certain medications. And fourth, of course, the poor patient compliance, not only because it's a lifelong disease, but also because they suffer from the comorbid illnesses and making the multi-drug therapy. All the current therapy of the diabetes, they revolve around either the insulin secretion or insulin action. As you all know, there's a sulfonylurea. Insulin is of course related with the insulin secretion. Incretins also related with it. Metformin and glitazones are related with the insulin resistance. So whole story revolves around the either insulin secretion or insulin action. So if you evaluate the existing molecules, the limiting problems, we know that in case of the sulfonylurea and insulin, there is a risk of hypoglycemia, there is a risk of weight gain. But in case of the glitazone, there is a risk of weight gain, edema, and risk of fracture is also high, especially in the postmenopausal females. While with the DPP-4 inhibitor, it's a weight neutral drug and low risk of hypoglycemia is there. With the GLP-1 analog, weight loss will be there, but the one important disadvantage is that it is an injectable molecule. This is the ominous octet suggested by the De Franzo. We all know that in a diabetic patient there is a decrease in creatine effect, decrease insulin secretion, increased glucagon secretion, increased hepatic glucose production, decreased glucose uptake, increased lipolysis, and increased glucose reabsorption. I would like to focus on this, especially the new dimension is targeting the kidney. Till date, we knew about the role of the kidney in diabetes, that increased blood pressure or increased blood sugar causes nephropathy. In the term of that, it causes microalbuminuria, which is a CV risk marker also. Till date, the kidney was a victim. But we should know the role of the kidney as a glucose regulator. There are three important functions of the kidney. One is the glucose release, that is gluconeogenesis. And the kidney is responsible for about 25% of the gluconeogenesis of the body. And it also utilizes the glucose. It utilizes about the 10% of the all glucose for its energy need. And the third important part is that the glucose filtration and absorption. So the kidney has three important roles to play, that is production of the glucose, utilization of the glucose, and reabsorption of the glucose. So there is a paradigm shift from a victim to an ally. The kidney as an emerging target for the treatment of type 2 diabetes. To understand this, we should know the normal renal glucose handling, that what happens in our body. What happens, about 180 liters of the plasma is filtered every day in our proximal tubules. And if you see, if our body glucose is about 90 to 100 milligram per deciliter, what happens, about 180 gram of the glucose is filtered through it. But most of the glucose, a majority of the glucose is reabsorbed by the SGLT2. And remaining glucose, 10% is absorbed by the SGLT1 in the proximal tubule. SGLT2 is situated in the S1 and S2 segment of the proximal tubule, while SGLT1 is situated in the S3 segment of the proximal tubule. You can see in this diagram that 90% of the glucose absorption takes place by the SGLT2 in the S1 and S2 segment, while 10% of the glucose is absorbed by the SGLT1, which is situated in the S3 segment of the proximal convoluted tubule. So that's how almost all 180 gram of the glucose which is filtered is reabsorbed, and almost negligible glucose excretion is finally there. This is the normal physiology. This is the difference between the SGLT1 and SGLT2. SGLT2, as I told, it is situated in the S1, S2 segment. It has a specificity for the glucose, while the SGLT1 has the specificity for both glucose and galactose. SGLT1 is situated not only in the kidney, but in the intestine also, where it absorbs the glucose. SGLT2 has the low affinity, but high capacity for the glucose transportation. So the SGLT2 receptor, this is the ideal target to reduce the reabsorption of glucose because it has the low affinity but high transporter capacity. So that's why the SGLT2 receptor, SGLT2 blocker has developed. What happens in the diabetic patients? In the diabetic patients, the glucogenesis is increased in postprandial and post-absorptive states in type 2 diabetes patients, and it has been seen that threefold increase relative to the patients without diabetes is seen. So the gluconeogenesis is high in case of diabetes. Similarly, the glucose reabsorption, because the increased SGLT2 expression and activity in the renal epithelial cells is also seen in diabetics as compared to the non-diabetics. You can see from this is the cultured proximal tubular epithelial cells. You can see as compared to the healthy persons, in the type 2 diabetic patients, the SGLT2 and GLUT2 are more as compared to the healthy person, and that's why the glucose uptake is higher in the diabetic patients as compared to the healthy patients. So the glucose transporters and the rationale for the SGLT2 inhibition. First time this was seen with the discovery of the fluorescein by French scientist, chemist in the early 1800s. And he isolated a substance, that is fluorescein, from the bark of the apple tree. And this is the German physician and diabetes pioneer, Joseph Hahn, who demonstrated the glucosuria at the high dose of fluorescein. And in the early 1970s and 1990, the research with the fluorescein revealed that the location and characterization of the SGLT2 receptors. And in the 1999, the first molecule, that is T1095, was reported as a novel approach for the treatment of the diabetes. But I would like to tell here that the fluorescein was used initially not only as an anti-diabetic, but for the treatment of malaria, infectious disease also. But the one disadvantage with the fluorescein was there, as I have discussed, that it was not selective for SGLT2, it was a non-selective. So the side effects like malabsorption, diarrhea developed because it also blocked the SGLT1. So newer molecule, that is dapagliflozin, canagliflozin and empagliflozin, were introduced from the 2012, and the first molecule to be approved by the US FDA was the canagliflozin, then dapagliflozin, empagliflozin. So I'm going to discuss about this molecule, that is canagliflozin. It's an orally active inhibitor of SGLT2, and which is the transporter responsible for the reabsorption of the majority of the glucose. Its affinity for the SGLT2 is 250 times higher as compared to the SGLT1. As I have told, there must be high affinity for the SGLT2 receptor because that is clinically useful. The mechanism of action: by inhibiting the SGLT2, it lowers the renal threshold for the glucose. You can see, as compared to the healthy person, in the type 2, the renal threshold is higher. But what does the canagliflozin does? It lowers the renal threshold, so it increases the urinary glucose excretion up to 80 to 120 milligram per day. And in most of the studies, it has been shown that it causes about the 70 gram per day excretion of the urinary glucose. It's obvious from this slide that the renal threshold has been reduced. This is the placebo. As compared to the placebo, you can see that with the canagliflozin and DEP 100 milligram and 300 milligram, the renal threshold has decreased to about 90 to 120. Absorption, has a rapid and good oral absorption. Bioavailability is about 65%. Plasma protein binding is 98 to 99%. No clinically relevant active metabolites are seen. Excretion is mainly through the feces, that is 51.7%, and 33% in the urine. Terminal half-life is 10.6 hours with the 100 milligram and 13.1 hours with the 300 milligram of the canagliflozin. And the food, gender, age, race doesn't differentiate, doesn't alters the pharmacokinetics of the canagliflozin. So I'm going to show certain important studies. The canagliflozin treatment and trial analysis, that is Cantata program, is a robust phase 3 clinical development program conducted in more than 10,000 of the subjects which were enrolled globally. This was not only monotherapy, but dual therapy, triple therapy, and with combination of the insulin. And the patients were enrolled from all over the world. It was from the 49 countries, not only America, Europe, South America, Australia, Africa, but the patients were also from South Asia. And the Indian subjects were, as Dr. Thakkar discussed, we are genetically different. In these studies, about 11% of patients were from the India. It means about more than 1100 patients were Indians. And you can see these are the various studies, that is monotherapy, add on to metformin. And this is the demographic profile of the patients, you can see. And the studies were conducted in 26 weeks and 52 weeks. And I will present some studies one by one. Efficacy and safety of canagliflozin monotherapy in subjects with type 2 diabetes inadequately controlled on diet and exercise. Means let us come to the glycemic efficacy. You can see as compared to the placebo, there was a significant reduction in the HbA1c. With 100 milligram, there was a 0.91% reduction of the HbA1c. With 300 milligram of canagliflozin, there was a 1.16% reduction of the HbA1c. And as Dr. Thakkar discussed, higher the baseline HbA1c level, more the reduction. So in this subgroup analysis, when the baseline was 10.6, the reduction of the HbA1c was much higher, that is 2.13 with the 100 milligram and 2.6% with the 300 milligram of canagliflozin. There was also greater proportion of the subject who reached HbA1c level, as you can see, compared to the placebo. 44.5% patient achieved HbA1c target of less than 7%, and with the 300, higher number of patients achieved the target. Similarly, HbA1c less than 6.5%, about 17.5% patient achieved less than 6.5% of the target with 100 milligram of the canagliflozin. Similarly, the reduction in the fasting blood glucose, you can see, it provided a significant reduction in the fasting as well as postprandial. You can see 2 millimole and 2.4 millimole reduction in the fasting glucose and 2.4 and 3.3 millimole reduction in the 2-hour postprandial glucose. So it was efficacious in reducing the HbA1c, fasting and PP. But not only the reduction of the hyperglycemia, but there were certain extra glycemic effects, benefits, which are found to be very useful in the management of diabetes. Because we all know that the weight gain is a very important issue in the diabetics. Every 3 kilogram weight gain offsets the benefit of the 1% A1C reduction. And the canagliflozin, 100 and 300 both provide a significant reduction in the body weight. You can see with the 100 milligram of the canagliflozin, about 2.2% weight reduction was seen. With the 300 milligram of the canagliflozin, there was 3.3% weight reduction was seen. Not only this, it has a very good effect on the blood pressure, reduction of the systolic and diastolic blood pressure also. You can see with this there was a 3.3 millimeter systolic blood pressure reduction with the 100 milligram of the canagliflozin and 5 millimeter of the systolic blood pressure reduction with the 300 milligram of the canagliflozin. Similarly, diastolic BP was also reduced, however it was not a predetermined study. And as far as the pulse rate difference is concerned, there was a minimal changes in the pulse rate were observed with the canagliflozin 100 and 300 milligram compared with the placebo. Changes in the fasting plasma lipids. There was a little bit reduction, it was not significant in the triglyceride. There was significant increase in the HDL as well as modest elevation of the LDL. You can see there is an increased HDL, increase in the LDL also, and there is a little bit increase in the non-HDL also. But if you see the comparison of the LDL by HDL, this LDL-HDL ratio is reduced because the increase of the HDL is much higher as compared to